Well, thank you all very much for being here with us. We're waiting for a few more people just to come into the door. I want to remind everybody that, of course, we have part 2 things going on tomorrow morning. So I look forward to seeing everybody then. And if you have, just as before, we're going to have presentations, and then after the presentations, we'll have a question and answer session. So as you hear our presenters giving information, please make notes to yourself about things that you may want to ask a question about. Otherwise, but we want to make sure you're getting involved with this. So first I'll just begin. I'd like to welcome you to this session entitled, After Your Diagnosis, Navigating Your Healthcare Journey. We'll talk about building your healthcare and support team and becoming comfortable as an advocate for yourself, because the one person you can always depend on or should always depend upon is yourself. And so we want to empower you, make you comfortable, because some of us get kind of afraid when talking to that white coat. Of course, not these people up here, but you'd be afraid to talk, and so we want to make sure you're feeling comfortable. I'm going to introduce all of our speakers now, and then we'll hear from each one of them afterwards. Our first presenter is Dr. Ugo Ezema. Dr. Ezema is a critical care pulmonologist with Terrebonne General Hospital System. He is passionate about lung health, teaching, and mentoring young students. Dr. Ezema. No, stay there. Just say hi to you, man. After I finish, everybody. Our second presenter is this young lady's surgeon. You were talking about him earlier today, about Dr. Pettiford. Now you won't even look up. All right, never mind. The second presenter is Dr. Brian Pettiford. Dr. Pettiford is a thoracic surgical oncologist and is the section head of General Thoracic Surgery and System Program, as well as Director of Thoracic Oncology and General Thoracic Surgery at Ochsner Health. And for those of you who keep score, he's a Morehouse graduate. Because if you couldn't get into Howard, you go to Morehouse. Okay. Our third speaker is Ms. Anisha Pryor. Ms. Pryor is a nurse navigator with the Louisville Comprehensive Cancer Program and Control Program through the Louisiana Nurse Navigator Assistance Program. As a certified oncology nurse, she both works directly with patients who are being treated for lung cancer, providing chemotherapy, while also stressing the need for increased screening for these patients. So we're going to begin with Dr. Ezema. Please, sir, would you like to sit here? Come on up, and we'll keep going from there. Thank you, sir.
Good afternoon, everyone. How's everyone doing? It's a tremendous pleasure to be here with you guys. This is a wonderful, wonderful conference and highlighting something that's very important for our community and our people. Let me see, do I just press?
Yes, sir. Yeah. 1 second.
Oh, he said.
Yeah, click. Okay. Yeah, that one, sir.
Yeah, he told me to wait.
Yeah.
Oh, before we get started, what questions do you have? Oh, yes.
I'm a survivor, eight years at the end of this year. And I'm still actively under treatment. I currently do not have a pulmonologist on my team. It's a long story. But I'm curious about how important, I mean, it might seem an obvious question, but I haven't had one really for about a year and a half. How important is it for a lung cancer active and treated patient to have a pulmonologist? Like what's the, when I used to go, she didn't offer me much. And so I'm just wondering, what should we be trying to get from our pulmonologist?
That's a great question. Why don't you hold it till we finish the 3 speakers, because it's going to be addressed. That's why. He did, but I'm telling you when the answer is going to come, though. So that kind of sets us up for one of the things. So I got no problem with that. I'm just letting you know the answer is going to be coming forthwith. No, you did good. That kind of helped us.
But definitely glad to see you here for sure.
And you also may want to talk. We have a nurse navigator that's going to help, and now that he's volunteered, he's going to give you his number.
Okay.
1 second, sorry.
Okay.
Still trying to get who happened to give the advice. was great. We will get back, and we'll get back to that. I could tell bad jokes. No, take your time, take your time. As Dr. Pedford would tell you, I'm sure doing his part when he was doing heart surgery, as he used to always say, take your time, sir, the patient's on time.
All right. So my presentation is about when lung cancer becomes urgent and what patients and their families need to know. As a lung and ICU doctor, unfortunately, by the time that I do get to see lung cancer and by the time it becomes symptomatic, the challenges and the stages associated with it and the timing of intervention becomes a little bit more problematic. The unfortunate thing about lung cancer, of course, is that we diagnose it far too late often, and a big shift is trying to get to the diagnosis of lung cancer earlier. Oh.
Down is forward on that. Oh, down is forward.
Down is forward, I like that. Okay, so why this talk matters. I've kind of highlighted this a little bit. Lung cancer is the #1 cause of cancer-related death in the United States, more than breast, colon, and prostate cancers combined. It's an underdiagnosed cancer, unfortunately, and it's one that is often found too late. I think we can all agree that there's a stigma often attached with lung cancer because it's usually associated with smoking, and so it doesn't get the fanfare that other oncologic diseases do get. Black Americans especially face the lowest 5-year survival rate of any racial group and are 15% less likely to be diagnosed early. So broadly, we're diagnosing lung cancer very late, and in the Black American community, even later than your average. So understanding how lung cancer shows up in urgent situations can help us, help you and your families, our patients and your families, be prepared and to be vigilant about getting a diagnosis and getting to treatment as soon as possible. Sometimes it does announce itself loudly. Lung cancer is often found quietly. But like I mentioned earlier, by the time you get to your symptoms, it's usually a later stage manifestation. But some common urgent symptoms that you can see: difficulty breathing, so shortness of breath, cough, coughing up blood. Often you can get fluid in your lungs, and at the very worst, you're admitted to the hospital, or if you're having any sort of organ failure, in this case it will be your lungs, you're being admitted to the ICU. So it's important to keep, especially in patients that have a higher risk for lung cancer, either by family history or by their own personal history, smoking history, we highlighted that earlier, and age. If there's any risk for that, being mindful for our family members and our community members for any possibility or any of the symptoms that may be a manifestation of lung cancer. As a lung doctor, what do I do? The lungs are my organ of choice and specialty. Where lung cancer is concerned, our tools that we use most often is a bronchoscopy, which is a scope that we use. We enter into the lungs through the windpipe, the trachea, and get into the lungs and look at the major airway branches. Now, in the last several years, we've had some significant advancements in our bronchoscopic techniques, and we're able to navigate to the very peripherals of the lung and to evaluate the airway, and at the same time get biopsies of lesions, nodules, which are smaller spots or lesions in the lung, and masses, which are bigger ones in the lung. So we've made tremendous strides in the last few years with our ability to get to different quadrants, different parts of the lung. In fact, I would make the case that we can get to all parts of the lung with the tools that we have available to us, modern tools that we have available to us. We also, when there is fluid in the lung, specifically fluid around the lung in the pleural space, which is if you think of the lung as two balloons, one inside the other, there's a little thin space that often they just slide on each other, but fluid can build up in that space as well. And that can itself be a manifestation of lung cancer. We also can drain that fluid, send it off for studies as well. So that's a part of our scope of work. When it comes to managing these symptoms, the most important thing, of course, is to stabilize the patient. If they need oxygen, if they need non-invasive support, so breathing apparatus that isn't being intubated or being on the ventilator, and certainly being on the ventilator if necessary, we can alleviate some of that pressure that can be compromising the airways, that can be compromising the lungs' ability to, or the respiratory mechanics, which is the diaphragm contracting to allow the lungs to, pull in the air for you to have a good deep breath. Having fluid in that pleural space can compromise that. So alleviating that pressure, and also the pressure that can also compromise your blood flow if there's enough pressure there. So alleviating that pressure through draining that fluid in a procedure called a thoracentesis can help improve breathing. And if there's any sort of airway compromise, we can help restore airflow. The most important thing is to, one, alleviate the symptoms as best as we can, and to get answers as to what's causing the symptoms. So I would make the case that is your overall algorithm of how we address the symptom management. These are 4 questions that I would recommend to be mindful about if someone is in the ICU or has been admitted for a lung issue. What's causing the breathing problem now? And that's often something that's readily identified based off of the tools that we have available to us, either by imaging or by clinical blood tests, et cetera. Imaging is an easy one. If it's a chest X-ray or CT scan, you can see a lot of things based on the radiographic presentation. What tests are being done, and when will those results come back? I think this is a very fair question to ask any of the providers that are taking care of our patients and our loved ones. The timing of when they're come back, a lot of tests don't come back same day. They can be sent out, and especially if it's one that we don't do often or commonly. Who is on the care team and who should we talk to? We being the family members. Who is part of the care team? Has the primary team already thought about the lung complications? Is a pulmonologist on board? Is there something where a thoracic surgeon may be beneficial to, have they identified something in the lungs where a thoracic surgeon may be beneficial to get on board quicker while they're inpatient so that we can start making arrangements for what's necessary? On the rare occasion, if there's a diagnosis while in the hospital, is the oncologist on board. So there's a wide variety of specialties that could be beneficial to be a part of the team, and I think it's important to ask that question, who is part of the care team? A lot of medicine is shifting towards a multidisciplinary approach, in which case we understand and recognize that having a collegial relationship with our different specialties improves outcomes for our patients, and this is part of this question kind of highlights that as well. And then what are the next steps after stabilization? So once we've stabilized the patient, the next steps being, of course, trying to figure out exactly what's driving the symptoms in the first place. So during a crisis, it's completely understandable to be overwhelmed. A lot of things are going on. One thing that I strive to remember is that while the hospital and the clinic is my day job, it's my office, it's a very strange place for everybody else, right? So being in a hospital, being in a clinic is not a normal experience. For me, I just go get coffee, get my tea, I'm good. But anybody else that shows up, patients that show up, family that shows up, it's a time of vulnerability and it's a time of concern. Often it is. So it's okay to be overwhelmed. I think lean on the expertise of the staff of the care team so that it can help at least clarify any concerns, questions, reservations that you may have. Like I said, ask questions. I always tell my patients and their family members, for some reason when the providers are in the room, you forget all the questions you need to ask. So my recommendation is pay attention as best as you can while they're there. Start writing the questions down the minute they come. So come with a notepad. We all have phones. We all have smartphones. Most of us have smartphones. Type it in a little note. And when the opportunity comes again, don't be sure or don't hesitate to go ahead and ask those questions. Most, if not all of us, are going to be more than happy to alleviate, because it's part of our job, right? Our job is not only as providers, but also as educators, right? Our job is to help you feel informed about what's going on so that as things happen, we're all navigating through this with shared decision making. You don't have to make every decision immediately, and this is an important point to recognize. A lot of times you feel pressed, and we are action-trained providers. If something is happening, we want to do something. That's the way we've been trained. And if you're in the hospital, if you notice something, you might wonder, something needs to happen. Often, taking the moment to collect yourself and making a decision that is composed and informed. So take the time to really think about for yourself, if you're the patient, and if it's for the family who's making decisions for the patient, to really make sure that you're doing what best represents what it is for the patient or for yourself, something that you feel will be best for you. The first goal, of course, if anyone is symptomatic, is to stabilize. And in the hospital, that is going to be the primary directive. So a lot of things could be happening and a lot of things could be going on, but just recognize that the team is there to help and to support and to stabilize. It's important when the time for diagnosis and care when it's time for that, is to ask for a patient navigator. These are I would go so far as to say these are going to be your most important relationship, because they help to, it's in the name, they help to navigate you through what's a very, very complex system in a hospital. And help you navigate through a very difficult time. You can imagine doing anything else. You need a navigator, and they have different names in different fields. When it's tax time, you need a navigator. That's your CPA. So in different parts of life, we accept navigators. Why wouldn't we accept it when we have a really challenging diagnosis? A crisis does not mean there's no options. Many patients go on to receive effective treatment. Lung cancer has made tremendous strides, not only in diagnosis, but in treatment, and that continues to improve. Every year, we're going to have new and better options. So it's important to explore your options, be curious about what's out there, be engaging for the family and for the patient. Talk to your providers, talk to the different parts of the care team, so that everybody is aware of, one, your interest and on your family and for yourself. I read a study once about, and this is slightly tangential, but I suspect it can be translated to care in general. In nursing home patients, the patients that do really well in nursing homes are the patients whose families ask the most questions. So the patients whose families are present are, for some reason, and we all know the reason, the staff becomes a lot more vigilant about how they care for that patient. So that's just human nature. So a part of our duty for our families and for ourselves is to stay aware and to pay attention, to be vigilant. Our friends and family that are going through lung cancer are going through a very difficult time. They might not have the energy, they might not have the strength, they might not have the thing to drive through, and that's where we're going to have to stand up and be heroes for them. So the best crisis is the one we can prevent. 1 in 5 lung cancers are found at an early age. The opposite of that means that 4 out of 5 are found at a late stage. So we have a lot of work to do. And only about 6% of eligible Americans and only about 20%, just under 20% of eligible smokers are actually being screened for lung cancer. So I would make the case that we functionally have a diagnosis, we functionally have a cure for lung cancer, and it's early diagnosis. If you find it early, your chances of surviving are much, much, much higher. And if there's anything you can get from for me today, it's exactly that. That if lung cancer is to be found, we should make every effort to find it as early as possible. Low-dose CT scans is one of the premier, if not the cornerstone of lung cancer screening, and it's covered by insurance for high-risk individuals. So it's something to think about for our smokers between the ages of 50 to 80 who are continuing to smoke or have quit within the last 15 years. Black Americans who are screened had the greatest reduction in lung cancer mortality of any racial group. So when we get screened, we catch it early, and we have the greatest reduction in lung cancer mortality. So there is room for tremendous improvement for us. Oh. Lost my battery. So the four things I want you to remember. Lung cancer can become urgent very quickly, so know the warning signs. The pulmonologist, me, and people like me, stabilizes you or helps to stabilize you along with other parts of the care team and get answers quickly. Ask questions. Be inquisitive and be present for yourself and for the patients and for your family. And early detection is the best way to avoid a crisis. A crisis is not the end of your story, it's the beginning of your care. So if there's anything I want to leave you, which is, again, be vigilant and to, have a sense of resilience, because we have room for improvement, and we can certainly make a significant dent and change in lung cancer care.
Our next speaker is Dr. Pettiford, and we're here at Thoracic Surgeon's Perspective.
Good afternoon. You know I was not going to let that comment about Howard and Morehouse slide. The first black president of Howard University was Dr. Mordecai Johnson, a Morehouse man. All right. So the title of my talk is After Your Diagnosis, Navigating Your Healthcare Journey. So you were just diagnosed with lung cancer. Now what? Take a deep breath. It's a gut punch, just like any cancer diagnosis. And I don't think there's a single person in this room that has not been touched by cancer, either themselves or a close family member. You have to understand that this will be a process. It's not going to resolve itself overnight. There are stages of it. It has to be diagnosed. You may come to the hospital, and all that you know that there's a spot on your lung. You have to get a diagnosis. Then you have to determine the extent of the cancer. That's called staging. Once you have an idea about the stage, then a treatment plan can be formulated. You have to also understand that you are now the center of attention. And there's going to be a team of people taking care of you. This is not the cancer treatment from the 1970s, 1980s, and 1990s, and for that matter, the early 2000s. So we have a team approach now, and Dr. Azima just mentioned that. It's a multidisciplinary approach. And you see all of the key players here, but the patient is the most important person here. It's important for you to educate yourself. You don't want to just believe each and every word that your physician or nurse navigator tells you. You need to get out and educate yourself. Write down the questions. When you're in that office and you're speaking with that healthcare professional, your mind's going to be spinning. We have a finite amount of time. We got a whole lot of other people we have to see, and we have a lot of stuff to go through. You're not going to remember all of that. So as Dr. Azima mentioned, write stuff down. Serve as your own advocate. If something doesn't sound right, it doesn't feel right, speak up. And you have to also listen. Okay? You have to listen. You're not alone, so don't come to your appointment alone, if possible. I cringe every time I have a person that comes in and that individual is by him or herself. They're going to go home, and the family members are going to have a bunch of questions, and they're not going to be able to answer them. I've had on more than one occasion, on the day of surgery or a few days before surgery, an irate family member calling, why y'all taking my mama to surgery and nobody called me and told me about it? Okay? What are y'all doing? So bring a family member, someone to help you out. And remember, your situation is your situation. Yes, I know that your family member may have had lung cancer in 1975. Things were different in 1975. Everybody's situation is unique. The past is the past. You get the diagnosis? Okay, you got the diagnosis. What's next? You can't perseverate on the fact that you got the diagnosis of lung cancer. You got to look at the next step. Okay? Get yourself in fighting trim. There's more than one cause of lung cancer, but let's be real. 90% of all lung cancer in the world is smoking related. There are other causes. There are some people that have never seen a cigarette and they get lung cancer. There's a loose association between radon exposure and lung cancer, asbestos exposure and lung cancer. But if you're a smoker, you got to stop smoking. You got to do everything in your power to help yourself out. Okay? You can't. Once you have that diagnosis, it's there. You can't do anything about that. You have to focus on what you can take care of. So stop smoking. If you're vaping, stop vaping. We don't know what's going to happen with people that are vaping. It's too early. I guess maybe in the next 10, 15, 20 years, once we see the effects and people, I don't know, have horns growing out of their heads from whatever chemicals in these vape machines, just stop vaping, okay? And increase your mobility. If you're facing the prospect of surgery, start moving around and get yourself prepared for a favorable outcome. You have to compartmentalize your journey. And remember that this is a process. And I go back to what I said earlier. This is your situation. It is your diagnosis. Forget about what they said. No one, and by the way, no one can ever tell you who they are, okay? They said this, they said that, but no one can ever tell you who they are. Focus on yourself. And one of my earlier slides I mentioned, do your own research. You have to also be careful. There's a lot of stuff on the internet. I've been doing this, I'm entering my 23rd year of practice and including my training, almost 32 years. There's some stuff on the internet that can confuse me, okay? So you have to be careful with what you're reading on the internet. We've had patients with early stage curable lung cancer. I've had them come into my office, and we're seeing it increasingly, saying, oh, I don't want the surgery, I don't want radiation, I'm going to take ivermectin, because they said ivermectin works for lung cancer, okay? You have to be careful about what you read, all right? I think, they gave us 10 minutes, so I wanted to stick with the time. I do want to acknowledge the presence of a very special lady here, Miss Janie Blackman, a very brave soul. We've had the privilege of taking care of her, and I have to say, I can't imagine how it must feel to have a diagnosis like that, okay? She came in, and she was a soldier. Every appointment, she was there. Always a good attitude. How you doing, Miss Blackman? Oh, I'm blessed. Always came in with a smile on her face. Even during her hospitalization, after what is a painful surgery, was still all smiles. So all of the stuff that I mentioned in terms of getting yourself prepared for surgery, she did it. And she's sitting there with a smile on her face this afternoon.
Dr. Pettifer, I think one of the reasons why she is so comforted and comfortable when you're in the hands of someone who you know who cares about you, it makes everything so much better. So thank you for taking care of her. We appreciate that. Our next presenter will kind of tie things together. And about as far as what's the role of the nurse navigator. And our presenter is Ms. Anisha Pryor.
All right, so I'm going to talk to y'all a little bit today about navigation, lung cancer screening support, and resources. And y'all might hear me repeat a lot of what my colleagues have already said, so I'm going to just drive it home. So what is patient navigation? All right, there we go. According to the NIH, patient navigation is a community-based service delivery intervention designed to promote access to timely diagnosis and treatment of cancer and other chronic diseases. It is individualized assistance offered to patients, families, and caregivers to help overcome real or perceived barriers in order to facilitate timely access to quality health care. Dr. Harold P. Freeman pioneered the patient navigation concept in 1990 after identifying health disparities in his community that negatively impacted health outcomes for people of color who were uninsured and underinsured. His focus was breast cancer screenings and timely follow-up of abnormal findings. By improving access to screening and decreasing delays to follow-up, the 5-year survival rate for Black women diagnosed with cancer increased from 39% to 70%, proving that patient navigation is an effective way to improve screening adherence, especially in vulnerable patient populations. Using the nursing process, a nurse navigator provides education and resources to facilitate informed decision-making throughout all phases of the healthcare continuum, and that is from screening all the way to survivorship. Dedicated registered nurses coordinate closely with healthcare providers and healthcare facilities to link individuals to necessary services. They connect clients to community resources to assist with overcoming structural barriers. And structural barriers can include transportation, child care, elder care, language barriers, scheduling conflicts, and health literacy. It is the navigator's responsibility to utilize available resources to resolve those barriers. For example, to address transportation, the nurse navigator might help you schedule transportation through Medicaid or Uber Health rides or gas cards if available. So in simple terms, navigators help people move through the healthcare system with less confusion, less stress, and better coordination. There are many different types of navigators, including financial navigators, treatment navigators, and outreach navigators, all there to help eliminate barriers to timely care and empower communities to take proactive steps towards early cancer detection and prevention. So shameless plug here. LANA is the organization that I work for, and we are a centralized virtual patient navigation program with the goal to increase cancer screening rates across Louisiana. Led by experienced nurse navigators, including myself, LANA connects individuals with resources and local and national support for cancers that can be screened, specifically breast, cervical, lung, and colorectal cancers. The program uses technology, including text messages and virtual engagement, to reduce barriers and improve access to preventive care statewide. We are partnered with the American Lung Association to provide lung cancer screening to those eligible throughout the state. We can help assist you with scheduling appointments for appropriate screenings, educate you on the screening process, and provide information on local and national resources. So if you are interested, you can scan that QR code or you can visit us at our table for more info. So why is this important? Lung cancer is the leading cancer of cancer death among men and women in the United States. It is the third most common cancer in Louisiana, preceded by prostate and breast. There's about 3,500 cases of lung cancers diagnosed yearly, and about 997 of those cases are non-Hispanic Black people. So let me ask, do y'all know who has the highest mortality rate as it relates to lung cancer? Black men. The answer is Black men. There's about 670 deaths per year related to lung cancer, and the majority of those are Black men. So why is that? According to the American Lung Association, Black individuals with lung cancer are 13% less likely to be diagnosed early, 19% less likely to receive surgical treatment, 11% more likely to not receive any treatment at all, and 13% less likely to survive 5 years compared to white individuals. Systemic issues often contribute to health disparities, and underserved populations face barriers like lack of information, economic issues, transportation, and limited access to health care, which can lead to delays in screening for cancer and detecting cancer early when it's easier to treat. Another barrier, specifically up until recently, there was no advocacy for lung cancer screening, so no one knew screening existed. You hear a lot about breast and colorectal, you see all the commercials for that, but there was not a big push for lung cancer screening up until recently. So what can you do about it? You can get screened. Screening saves lives. The U.S. Preventative Services Task Force and the American Lung Cancer recommend screening those between the ages of 50 to 80 years old who currently smoke or have quit within the last 15 years, have at least a 20-pack year smoking history, and be asymptomatic. Once you start having symptoms, it's no longer a screening, it becomes diagnostic, because then we're looking for a problem, and by then it's probably already advanced. Early screening can mean higher survival odds. Only 24% of new cases are found at early stages, while 50% is diagnosed late stage. When lung cancer is found early, treatment is more likely to be effective. And I want to show y'all this slide. It shows when most lung cancer cases are found. As you can see, the purple column shows that most of the cases are diagnosed late stage, and that's at 51%. And this slide shows the 5-year survival rate when diagnosed early. You can see it's at about 54%. When it's diagnosed late, it's only 7%. So that's a big difference. The overall survival rate is between 21 and 25%, but mortality rates have decreased. So we are moving in the right direction. All right. So as I previously mentioned, there was no push for lung cancer screenings, even though it has been around for over 10 years. Individuals were not educated about it. Transportation, maybe taking time off from work to have the screening done, may have been an issue. Even though there are programs to assist with screenings, access to those programs may be difficult, and that's where navigators come in handy. LANA specifically partners with the American Lung Association to help individuals find screening centers in your area, scheduling assistance if needed, transportation assistance, and tobacco cessation referrals if needed as well. So something a little different with lung cancer screening is that it requires providers to do what's called a shared decision-making forum with patients. It allows you to discuss the risks versus the benefits, and while benefits may include early detection, risks might include false positives or overdiagnosis, which may lead to unnecessary procedures. And although a small amount, some might view the yearly exposure to radiation as a risk. Shared decision-making, though, ensures patient autonomy, which leads to better adherence should treatment be required. Lung cancer is known as the disease of aging because the median age for diagnosis is between 60 and 70 years old, and getting older comes with juggling several other health-related challenges. So discussing those decisions allows you to plan for follow-up diagnostics and interventions ahead of time. It improves communication between you and your medical team by incorporating your values and your preferences into decisions, which also leads to better adherence. And one thing I left off this slide is a discussion about smoking cessation also must be documented. So I want each of you to feel empowered when speaking to your doctor about your health. Ask your doctor if you're at risk, because understanding your risk factors is crucial to determining the need for screening. What cancer screening tests are recommended for your age group? How often should you be screened? Ask about the procedures. What will happen during the screening? Are there any risks or side effects? How long will it take to get the results? Ask if your insurance will cover the screening. And if it doesn't, remember there are programs out there to help you cover those costs. This does not just apply to lung cancer screening. If there's ever a time you're not sure about something or you don't know the answer to something, don't be afraid to ask. Don't just take the doctor's word for it. Ask as many questions as you need to make an informed decision regarding your care. Don't be afraid to speak up. No one knows your body better than you do. Remember that. Use assertive phrases like, I know my body. These symptoms are not normal for me. And if you feel like you're not being heard or your needs aren't being met, seek a second opinion. Always advocate for yourself. Prepare in advance, write down your questions. Be specific about your symptoms. When they started, what makes it better, what makes it worse. And if you feel like you need extra support, bring a family member or a friend that you trust who can ask questions on your behalf and remember those details. Now, being a caregiver is an important job. As your loved one's #1 advocate, you play an important role. But remember, it is important to take time for yourself as well. Make time for yourself. Try at least 30 minutes of physical activity a day. Plan your meals in advance so you can maintain a healthy diet. Most importantly, get enough sleep so you can feel rested and ready to take on the day. Take time for yourself to do things you enjoy, going out with a friend, a massage, or watching a funny movie. When someone offers to help you, because I know we have issues with this, accept the help. There are many websites that can provide you with information, but make sure they are reputable websites that end in .gov or .org, because other websites may have inaccurate info and may be misleading. So this slide, if anyone is interested in smoking cessation, there are quick coaches available 7 days a week by calling the phone number. You can also scan that QR code. And I recognize that there's a negative connotation surrounding smoking, so this is a free and confidential service. And this slide just shows some resources for financial planning if anyone is diagnosed with cancer or if you're looking for screening resources. You can take a picture of this slide, or you can also visit our table for more information. And again, this is how you can contact me with any of that information. And that's it for me. Thank you.
Thank you very much to our panel members. I want to come back to the first question that we had earlier to this beginning of the session. And let's see. Stand up. Oh, you still said that's right. Now, would you ask your question one more time for us?
I wanted to get an idea of the importance of a pulmonologist, in particular for my care team. And just to say a few more words about it, I have had 2 pulmonologists over the course of my lung cancer journey, but right now I don't have one. And I want to know how they could enhance the care that I would be receiving as a lung cancer patient.
Thank you very much. So let's start off with you, Anisha. So she asked the question about the pulmonologist, where she could go, because it sounds as though you weren't heard or your concerns may not have been validated.
Well, my second oncologist was nearing pulmonologist was nearing retirement. He was a sleep medicine and a pulmonology specialist. He was great. He was wise. He had experience. He offered insight with my oncologist, and they collaborated. But my first pulmonologist missed my symptoms, failed to order a PET scan after I had a collapsed left lung. I was 44, a never smoker who had no information or knowledge about lung cancer and no reason to think I had it. My care was delayed by 6 to 7 months, and it's only by the grace that I did not die. I had a stage 4 diagnosis, and I'm just happy to be here. I don't sound like it right now, but I am, because I know I could have died.
Well, we're glad you're here with us. Okay, so this is clearly the worst case scenario we want to hear as a healthcare provider. So, therefore, because the person who is going to be the most caring, the person who probably is going to listen to the patient the most, is going to be the nurse. So, thank you. It's so, Anisha, let us start with you, and then we'll get other opinions.
So that is very true. We are the ones that you guys love to talk to more than you do your doctor. But I'm going to punt this one to Dr. Ugo because that's a more important question for him as far as
Some
the.
doctors are great, please don't get me wrong.
Absolutely.
I've had amazing doctors too, but sometimes they leave.
Yes.
You gotta find a new one.
Yes.
All right. So, but the question still comes down to, she needs to find somebody. How do you go about finding that physician who's going to take that time to do it? So we'll go ahead now. We'll go to answer that question for us then.
Yeah, a true survivor for sure, right? I think as the evening has gone by, I'm thankful more and more that you're here, and your voice is it's a very important voice. I think you should make sure that the people that can hear your voice, that you are an example of again, resilience and overcoming a lot of obstacles. And I'm sad that you went through that experience. With regards to the role of a pulmonologist once you've had the diagnosis and treatment, our role can be more of a maintenance, someone that keeps an eye on the lungs, right? So you just went through a very traumatic experience for your lungs. Our role is going to be one of maintenance and to make sure that someone is keeping an eye on those sneaky symptoms that could present again and is aware of that. Additionally, for people that are continuing treatment, and they're like Dr. Pettiford had mentioned, lung cancer treatment has gone some ways. A lot of those treatments do have side effects, and those side effects can manifest in the lung. In fact, often they do manifest in the lung, and we are part of the team, going back to the multidisciplinary team that helps to treat that. I think having points of contact in the healthcare system for people that care about you, as a patient and certainly as an individual, and given that it is lung cancer, I think having a lung specialist as part of your care team as you're navigating the continued survival is an important part of that process. Again, you are a tremendous story, and again, I'm really thankful that you're here today.
Brian, how would you respond to that, please?
First of all, you're a very resilient person. I want to apologize to you. It sounds like you were let down. There's no other way to describe it. In terms of the pulmonologist, a lot of different specialists, their level of input is kind of dictated by your state of health. So, for example, if you have stage 4 lung cancer and you're not having any symptoms, you don't have any fluid in your chest that Dr. Azima mentioned, there may be a limited role for someone like a pulmonologist or a thoracic surgeon. In that particular circumstance, the nurse navigator and the medical oncologist, the chemotherapy doctor, that's what a medical oncologist is, those professionals are the ones that will manage you. And what typically happens is that you will undergo periodic CT scans. And if there's anything concerning on the CT scan identified, that may be followed up with a PET scan, which I always tell my patients is kind of like a second or third cousin of a CAT scan. They're similar, but they are different. And if there's a need, you may get a biopsy if there's a concern about disease elsewhere. Sometimes it may be an indicator that whatever therapy you're on is not working properly, or it is effective. So you may not necessarily need a pulmonologist at this point. I think it would require a deeper dive into where you are in your current condition, and that will dictate what health professional needs to be involved.
While you have the microphone, Brian, we talk about this team concept, but one of the things is, how do we determine the therapy that this patient is going to get? So incorporate that, and then I'll have Anisha comment, because there are new and novel therapies. You kept a couple times saying this is not the care of the 70s, 80s, and 90s. So who decides how that treatment goes and if that patient is going to be a candidate for that?
In a perfect world, and quite frankly, the way it should be done is a team decides, okay? And the quarterback of that team is the patient, and the nurse navigator, excuse me, is the tip of the spear, okay? So that individual, the Anishas of the world are the ones that are gonna be your conductor through your treatment journey, okay? We generally, as a team, we meet and we discuss patients. Sometimes we discuss patients with very early stage cancer, but when we talk about patients that kind of have advanced stage cancer, when I say advanced stage, anything higher than stage 1 lung cancer, a team of people, a multidisciplinary team, and I think you've heard that theme between the three of us speaking, should be taking care of you. If there's one person that's driving the bus and they're making all of the decisions, you need to run, okay? Because that's not the type of care that should be administered to you in 2026. So a team of people will dictate your care, or at least present care plan to you. The stage of your disease, the type of your lung cancer and the stage of lung cancer will dictate the treatment strategies provided to you.
Anisha, please.
Also, with lung cancer, they're doing these next generation sequencing. So you can see if you have these PDL1s and all of these other, yeah. And so that also helps to determine what treatment you're gonna get, whether you're gonna get a platinum therapy plus an immunotherapy. So it's looking at those scans, it's looking at those next generation sequencing. And like Dr. Pettifer saying, you and your oncologist should be discussing those things so you can determine what's the best treatment for you, so that you are aware of whatever the side effects are, so you can plan for those types of things. You are the quarterback of that team, right? So your voice should be heard. And if you're feeling like that's not happening, then I would advise you to seek care elsewhere.
Shameless plug for tomorrow, but please be around because we're going to be discussing some new therapies, including AI and things. Dr. Pettiford and others will be part of that presentation, where we're going to get into some really, really interesting stuff. Please stand up.
I just wanted to mention that I think if it wasn't for my pulmonologist, I wouldn't be here. I was diagnosed with stage 4 non-small cell lung cancer, and he told me at my follow-up, my annual follow-up, that because of the way I presented, he probably wouldn't have sent me for my bronchostomy, but something just told him to send me. I just had a cough. I was healthy besides that. So I just wanted to, thank the good doctors, like, you seem to be, because when you guys take just another moment to look at your patient and say, something is just not right, and just have the mindfulness and thoughtfulness to send patients for that additional testing, I wouldn't be here if he hadn't thought to do that. So I just wanted to say there are really some good doctors out there.
More importantly, thank you very much for that. More importantly, I'm kind of concerned. How many times have we heard someone in this audience say stage 4 cancer, their diagnosis? Where are we missing the boat on this? We are missing, yeah, we are missing the boat. I'm going to take two more questions. Please stand up, because I got to get back to this crazy lady.
Right, sure. So I think the question that I have as someone who was diagnosed at the age of 36 is where I feel like we're failing our individuals by not the right education about screening. Y'all all have talked about screening today, and the screening guidelines really talk about those who have been smokers, but what about us who are non-smokers? How do we change those guidelines or increase education so that we won't have this continued conversation of missing? The statistics are up there about what happens when we are screened earlier, and like me and many others here, we were misdiagnosed for several years, right? So I think that is the missing piece, especially within our community.
Each one of you, answer that question in order, if you would, please. Each one.
Yeah, so unfortunately, there's a rising rate of non-smoker lung cancer. So unfortunately, as well as in younger folks. So right now, the standard guideline for recommendation is primarily focused around smokers. I think something to be mindful about with regards to, now we're probably going to shift towards a much more standardized overall screening as lung cancer becomes more and more prevalent, unfortunately, because that's also rising. I think as public health policy improves, we're going to move towards that at some point. Now, what those criteria are going to be is still up for question, and when that happens is still up for question. I do think it's important to note that there are certain limitations that the current healthcare system contributes to why we diagnose things later. For instance, a patient may come in for a cough today, and it takes a month to get to get a workup, and then your follow-up is in 3 months. And then if nothing has changed between those 3 months, you might stretch that out for 6 months, et cetera, et cetera. I think we've all experienced that with our healthcare system, not to mention the clinic burden and the time limitations that we often have in clinics, et cetera, et cetera. I do think that being a mindful provider means being extra vigilant on our part. So from an individual provider perspective, and hopefully that becomes much more standardized, is if something isn't, what's the definition of insanity is doing the same thing and expecting a different result. So if that applies to clinical symptoms as well. So when when nothing is changing despite your best interventions, then the next step is probably a new intervention. So I say that in the sense of lung cancer is a diagnosis that we can make with radiographic tools. My threshold for getting a CT scan is relatively low, to be fair. If you're coming to me and to see me and you have a cough that I've maximized my otherwise normal treatment options, and I think this is standard of care. We want to go ahead and make sure we're not missing anything crazy.
Brian, how would you respond to the same thing?
First of all, thank you for that question. That old saying, when you hear hoofbeats, you think horses. And so one of the reasons why folks who are non-smokers are not screened, quite frankly, we don't have adequate screening tools, okay? The National Lung Screening Trial, that's where the screening CT scans are, that's why they are applied. That was used in smokers, and it showed that there was a 20% reduction in deaths in people within a certain age group. Even with that, it took a while before these insurance companies and all these national bodies would agree for screening CT scans. There's also something that, in my professional and personal opinion, means more than screening CTs, is something called incidental nodules. That's where you're going in for a shoulder surgery, they get an x-ray, just part of your workup, and they see a little spot on your lung. That's going to be more effective, quite frankly, than these screening CT scans. We're not quite, I don't think, at a point where we can reliably identify folks who are at risk of developing cancer at such a young age. I think we'll eventually get there, but there's a lot of technology that we're going to have to go through in order to make a tangible difference. I will say this, though. The stuff that Dr. Azima does with the robotic bronchoscopy, I think he made some reference to it earlier, where we're able to go out and identify and biopsy very small spots in people's lungs. I think we're going to make a significant amount of progress in shifting the curve of lung cancer survival.
Anisha, you want to comment?
Add to that, unfortunately, it's kind of a wait and see kind of thing. I have asked those same questions. What about people who are under 50, who don't smoke, who have these issues? What are we doing? And nobody really has an answer for me yet. So it's just kind of a wait and see. those responsible bodies, like the U.S. Preventative Task Force that make those recommendations, they're responsible for changing, and it just takes time, unfortunately. It's the same thing with like how mammograms have changed. You know, they fought us for the longest. I'm telling you, as a navigator, we've had patients to come in who are 20 and 30. Oh, you don't need it. You don't need that. You don't need that. Well, what if I have a family history? I feel or not. We had to go to bat with these insurance companies to say she needs this mammogram because of this. So unfortunately, I don't really have an answer other than it's kind of like a wait and see until the powers that be determine that these rules need to change.
As good as this is, we have one last question. I'm going to take it here, and then I want to remind everyone, at the end of this, the speakers will be around, so please address them. So you go up and talk to them. They're going to be around. And also, at the Caregiver retreat area, just around the corner here, there's going to be karaoke and ice cream. I think karaoke is Japanese for drunk people can't sing, but anyway, stand up for me, please.
All right, so I had a question and Monique stole it, but now the question I was going to ask anyway, I'm going to change because Dr. Pettiford, you said that you guys don't have the tools to screen people who don't smoke for lung cancer, but it's the same CT scan. So what is it that's different about us non-smokers from anybody else? Like, and why is that test different? Because you're still looking for the same thing. You're still looking at our lungs. You're still looking at our chest. So what are we not qualifying for here?
There is an entity in this country called insurance. And those fools aren't going to pay for it. They're going to tell you, you got to pay for it, okay? Some of my patients don't have the wherewithal to get to the cancer center or to the radiology department. They don't have a ride. Now imagine having to pay for a CAT scan. And even in what I was referencing earlier, and that's a great question, is even with a trial that showed a 20% mortality, meaning if you got a CAT scan, a screening CT scan, versus those who didn't get a CAT scan, they got a plain old-fashioned chest x-ray, you had a 20% reduction in your likelihood of death as it relates to lung cancer. Even with that, and even with the U.S. Preventative Services Task Force and other national bodies saying, look, we support this, we think it should be used, insurers still fought it initially. So imagine a 30-something-year-old wanting to get a CAT scan. And what Ms. Anisha said earlier, you have women in their 30s who have clearly a family, they're at high risk of having breast cancer, they have a first-degree relative, and these fools don't want to pay for a mammogram. So imagine asking them to pay for a CAT scan.
So,
Yeah,
I will tell you, if for those of you who don't think that this is a question, you know, the intersection between healthcare and politics, this is it. For those of you who've chosen not to get involved in politics, i.e. by voting, please, I hope that you'll change your mind, because everything that we just talked about here, some of it comes down to looking at who's going to pay for it. So you're looking at Medicare and Medicaid payments, and you see who's being excluded from the various roles. This is a very serious matter. And as always been pointed out, catch something early, it's treatable in most cases. Ladies and gentlemen, this has been I don't know about you all, but I found this to be a most interesting session. Let's give them a hand, please.